How much more do we know about the clinical applicableness of CAC scoring, and how much do you think that cardiologists should look to incorporate this more into standard practice?
Yeah, so I've been a big advocate of coronary artery calcium scoring, or CAC scoring, as we call it, for now a few decades, since my early days as an investigator. But I can tell you that the evidence now is quite robust, to the point now, as you mentioned, it was incorporated into clinical guidelines. It's in the 2018 cholesterol guidelines from the American Heart Association and American College of Cardiology. It's in the 2019 prevention guidelines by the AHA and ACC. So it's getting more and more incorporated into our daily practice. And I think it's, we think about CT angiography, like we used in Evaporate, as a symptomatic tool. Coronary calcium is useful in the asymptomatic population. But to be honest, I think that if you want to know, does my patient have an increased risk of heart disease? Should I be worried about heart disease in my otherwise healthy appearing patient? There is no better test that we know of. And that's not my opinion. That's the opinion of the writing groups and the science. There is no better test to delineate who's going to be at risk of future events than who is going to not be at risk. And it's very simple. A score of 0, we call it the power of 0, imparts very low risk. And the guidelines say do not need to treat with a statin for the next 5 to 10 years, may help us adjudicate on blood pressure control, may help us adjudicate on aspirin use. So I think that there's a lot of potential benefits of knowing the calcium score, because we have a lot of therapies now. I mean, you think about all the therapies we could potentially give a patient, especially if they have diabetes, with GLP-1s and SGLT2s. We talked about icosapent ethyl, there's PCSK9s, ezetimibe, bempedoic acid, there's going to be inclisiran coming out. It's just a plethora of therapies on top of statins that we can add to help our patients do better, but we don't even know if they have disease. If they feel well, do they have underlying athero or not? So I find it to be the most useful test. And I have to say, almost every day in my practice, I am surprised when the thin, healthy person comes in to see me and they look like they're ready to run a marathon or go to the gym, and I find out they have a really high calcium score, and what the outside looks are somewhat deceiving. So I get serious about their prevention and I up their therapy quite a bit. And sometimes I see the overweight guy who doesn't exercise and his score is 0, and I'm a little bit less concerned about his cardiovascular risk, at least over the next 5 to 10 years.